Hello, everyone. On behalf of the National Alliance for HIV Education and Workforce Development, NAHUT, I would like to welcome and thank you for joining us on our monthly webinar series. I am joined by my colleague, Ashley Johnson. Before we begin, I would like to review some housekeeping items. We invite you to use the chat to engage with your fellow attendees. I see several of you have started to enter your information, which is great. Ashley has entered some questions to get you all started. So today's session is being recorded. The session recording and a PDF of the presentation slides will be added to NAHUT's website as a resource. You will receive this information in the post-webinar email that is sent out by Zoom after a day or so after this session. You can also visit the NAHU's resource page to find this information, as well as see the other past sessions that we've had. Throughout the session, please use the Q&A pod to ask your questions for the speaker. The speaker will address them at the end of the presentation. If there is time and you would like to ask your question live, you can raise your virtual hand and I will open your line to speak. So I also would like to provide some background on NAHUT. If you're not familiar with us, we are a membership organization of 8 regional and 2 national AIDS education and training centers, the AATCs. Established in 2010, NAHUT supports the AATCs, a component of the HRSA-funded Ryan White HIV/AIDS program, which have an explicit directive to build and maintain a well-educated and culturally sensitive health professions workforce that can provide prevention, diagnosis, care and treatment, and medical management for people at risk for and living with HIV. NAHUT collaborates with multiple organizations to promote and educate on the work of the ATC program. Since 2018, NAHUT has been funded by the American Academy of Addiction Psychiatry as a partner organization of the Opioid Response Network, ORN, to address the intersection of HIV and opioid use disorder. ORN was created to support efforts in addressing the prevention, treatment, and recovery of opioid use disorder. ORN provides free resources and technical assistance locally in communities across the United States and its territories. Please visit the ORN website for more information and or to submit a request for technical assistance. So today's session is accredited for CME, CNE, and social work. We will also provide a certificate of attendance if you choose that. We ask that you in order to receive your CE or certificate of attendance, we ask that you complete the evaluation. And even if you're not seeking CEs or certificate of attendance, we will love your feedback. That is how we use that information to plan out our sessions for the year. So we certainly take your feedback in consideration. We also provide your feedback to our speaker. So if there's something you want to share with the speaker, you can put that in your evaluation and that will be shared with Dr. Montero. The link for the evaluation will also be in that post-webinar email that's sent out by Zoom, but we will also add it in the chat towards the end of today's session. And if you have any questions, you can always feel free to reach out to me. We ask that you get 2 weeks. We ask that you complete within 2 weeks to receive your certificate. So at this time, I would like to introduce our speaker, Dr. Fernando Montero. He is a Chief Postdoctoral Research Fellow at the HIV Center for Clinical and Behavioral Studies at Columbia University. His mixed methods research studies the public health implications of recent transformations to the street drug supply in the United States, especially the emergence of synthetic sedatives such as fentanyl and xylazine, and stimulants, crystal methamphetamine. He focuses particularly on contemporary changes in the risk environment for HIV, HCV, mental health conditions, and fatal overdose among street-based people who use drugs in Philadelphia and the wider Rust Belt region. One of the central questions guiding his current research is why the opioid overdose epidemic is becoming increasingly Black, following almost 3 decades in which it was predominantly white and working class. He is also conducting a long-term ethnographic study of the war on drugs and militarization in the Afro-Indigenous region of Mosquitia on the Caribbean coast of Nicaragua and Honduras. So without further ado, I will go ahead and pass it over to Dr. Montero.
Hi, everybody. My name is Fernando Montero. As Liz mentioned, I am a medical anthropologist. I have 15 years of experience doing research on street drug economies in the United States. I lived in Philadelphia in the neighborhood of Kensington that's become somewhat famous now for its open air drug market. between 2008 and 2012. And I've been revisiting the neighborhood, working with the same group of people, working with my old neighbors ever since. So I and my research team, which is comprised of a number of medical anthropologists, including Philippe Bourgois, Laurie Hart, and George Carandinos, we have been able to observe the various phases or waves, as scholars call them, of the opioid overdose epidemic. The initial wave related to the overprescription of pain medications, further waves related to the emergence of fentanyl, and this latest wave related to the simultaneous emergence of combined fentanyl xylazine opiates and methamphetamine in markets that used to be dominated by heroin and cocaine, right? Predominantly in the Northeast and in the Midwest. So I'm going to share some slides. Okay, no, also it's a pleasure and an honor to be here. It's great to see in the chat that there's people from all over the country. I'm very curious to hear about your impressions, and very interested in hearing your questions. So the learning objectives for this talk are to understand how the sudden expansion of xylazine, fentanyl, and methamphetamine use is related to the history of U.S. drug markets since 1990. We're going to review the history of drug markets in the United States to understand the emergence of these new or relatively new substances. Understand how each of these substances relate to one another in the experience of consumption and in their public health impact, including on HIV and drug overdose risk, right? It's very important to understand the relation between these substances because increasingly in a growing number of places, people are using all of them together, right? So we can't just look at one drug in isolation. We can only understand xylazine in relation to fentanyl and also in relation to methamphetamine. And finally, we will review avenues for possible public health interventions that can minimize the risk of HIV, drug overdose, and related health complications, as well as interventions that might regulate drug markets to make them less toxic and less economically exploitative for both people who use drugs and for the people who sell them, right? So a lot of this is now common knowledge, right? When I first revisited Philadelphia after the COVID moratorium in 2021, it was not commonsensical, right? And there was not a very large literature on xylazine. I was very surprised when I revisited my old neighborhood and started hearing about tranq, right? This new substance xylazine, which has long been an animal tranquilizer. And people already had developed this kind of informal language, right? This nickname for the substance, which meant that it had to be pervasive, right? It was kind of like the first sign that the drug supply in Philadelphia had changed considerably. And so what my research team and I did was go back to the literature that we already knew existed from Puerto Rico, where xylazine was first identified as a heroin adulterant throughout the 2000s, especially in cattle ranching and horse breeding rural towns in Puerto Rico. People had been adulterating or using xylazine to enhance the effect of heroin, right? Interestingly, in Puerto Rico, many of the horses that compete in the United States and race horses in the United States are bred. And xylazine has been used not just for the treatment of the animals, but also to facilitate their transportation to the US mainland. And to this day, many of us still rely on that pioneering Puerto Rican health literature to understand xylazine and its health effects, right? So already that literature was very clear that xylazine was not an opioid, that it was instead an alpha-2 adrenergic agonist. And it was already the first literature to identify the link between xylazine use and these new health complications related to especially injection drug use, right? They identified that there was a novel kind of skin wound that was different from the traditional heroin abscess. They also identified the problems related to the fact that xylazine makes people fall asleep in awkward positions for extended periods of time, right? We're going to go over all these effects of xylazine, right? But it is important to bear in mind that xylazine is not an opioid. So to understand why xylazine emerged and how it emerged in the US mainland at this moment in time, it's important to understand the recent history of the street opioid supply in the United States. For 22 years, between 1991 and 2013, the heroin market in the United States was remarkably stable. There were two very clear monopolies in different parts of the country. So the West Coast had exclusively a Mexican form of heroin that is known as black tar. It's a gooey, waxy substance. While the East had a Colombian form of heroin that was a fine off-white powder. There were interestingly places in the Midwest like Chicago that had a combined supply that had both Mexican black tar and Colombian brown powder. But for the most part, the monopolies in the East and in the West remained in place and were remarkably stable. And these differences actually had significant public health implications. And this is why it's important to know this history and to understand the details of the textures and the consistencies of these different substances, right? So for example, epidemiologists found that HIV and HCV rates among injection drug users in the West Coast were significantly lower than HIV and HCV rates among people who injected drugs in the East Coast. And the reason for that is that the black tar form of heroin that was available in the West was this kind of solid, gooey substance that had by force to be heated in water before injection. And the heat managed to kill off a significant amount of these viruses, right? Whereas in the East Coast, the Colombian off-white brown powder that was available was very easily diluted in water. You didn't need heat. And in fact, in Philadelphia, I have never seen anybody use heat to dissolve the heroin or the dope prior to injection, right? And so that was having significant public health effects in terms of the levels of HIV and HCV among people who inject drugs. Now, starting in 2013, two things begin to happen. There was a shortage of Colombian heroin at this time, and we still don't really understand why that was the case. I think it's very important to connect with Colombian anthropologists and public health scholars to understand why suddenly Colombian heroin had trouble reaching the United States. But during this period, Mexican producers begin to experiment on how to basically make up for that shortage of Colombian heroin in the East Coast of the country. They kind of saw this as an opportunity to supply the East Coast and expand their market. And so they did two things at the same time. And it's very interesting because we've only heard about what they did with fentanyl, but we don't know that at the same time they were trying to produce this form of heroin, this new form of heroin that was exactly the same as the Colombian form, the powder that people were used to on the East Coast. So instead of trying to send black tar to the East, which maybe would have been a tough sell among people who use drugs there because they were used to this fine powder that was very easy to dissolve and inject, what they did instead was to try to mimic, to reproduce the kind of heroin that Colombians were producing. So they started producing a white powder, and at the same time, some of the same producers and other producers started experimenting with substances like fentanyl. And for 6 years, between 2013 and 2019, we had in the East Coast, especially, a combination of these two substances, this new Mexican form of powder heroin and fentanyl. And interestingly, we have learned that the substances were only mixed inside the United States at the local level. It was only local wholesalers, let's say in Philadelphia or New York City, that were mixing the heroin with the fentanyl in big quantities before sending them down to the street retailers, right? So it wasn't the Mexican producers who were combining the heroin with the fentanyl. It was only within the United States that was happening. It is around 2017 that Xylazine begins to make its mark in the Rust Belt region, beginning in Philadelphia. And it was only around 2017 also that fentanyl begins to spread west. So we spoke about the importance of these different kinds of heroin available in different parts of the country, right? Black tar in the west, a fine powder in the east. Fentanyl, which was powder, was only easily mixable into the powdered form of heroin that existed in the east. It wasn't easily mixable into the black tar solid gooey form of heroin that was available in the west. And for this reason alone, fentanyl was only present in the east for a very long period of time. Between 2013 and 2019, really, fentanyl was only an East Coast problem, not really a West Coast problem. In the East Coast, it entered the supply camouflaged as though it was still heroin that was being sold on the street. Whereas in the few places where it began to make inroads in the West, fentanyl was sold as what it really was. Like you couldn't fool anybody because heroin was this black tar substance. Then you come and try to sell this fine powder, people are going to know that it's something else, right? And so actually people knew that it was fentanyl that was being sold, and levels of fentanyl overdoses were much lower in the West Coast for a very long time than on the East, simply again because of these differences in the texture of the heroin that was available in each side of the country before fentanyl became a thing, right? Xylazine, interestingly, is a similar story. Xylazine is a powder, or is turned into a powder before it is inserted into the supply, and so it spread in the East much earlier than in the West. The story of Xylazine spread has been very similar to the story of fentanyl spread. As of today, actually, Xylazine is mostly an East Coast, Midwest, and Southern problem. The West Coast still does not have high levels of Xylazine adulteration. People are finding Xylazine in some samples, in some urine samples, but the levels of Xylazine adulteration are still much lower than in the East Coast and in the Midwest. It is around 2020 that heroin truly begins to disappear. The dope supply in the East Coast especially increasingly becomes a mix of fentanyl and xylazine, right? To this day, the substance is referred to as dope, but it is now widely known, even among people who use drugs, right, that dope is not heroin anymore. It rarely contains heroin. What people are using on a daily basis is basically fentanyl, and in a growing number of localities, it's a mix of fentanyl and xylazine. Another thing that happened roughly around the same time, starting around 2019, 2020, is that markets that used to be dominated by cocaine on the stimulant side of things begin to be dominated by a new form of Mexican crystal methamphetamine. That is very pure and very cheap. But back in Philadelphia, when I lived there between 2008 and 2012, I never even saw methamphetamine. What was sold on corners was heroin, cocaine, and crack. Cocaine was always a smaller market than the heroin market. People who use drugs, and I work predominantly with unhoused and marginally housed people, right? That is my realm of expertise. And for them, cocaine was always relatively expensive. They would only do it really when they wanted like an exceptional experience, like kind of as a treat, when they had a little bit of extra money, they wanted to feel something new or different. That's when they would do cocaine. But suddenly, when I returned to Philadelphia after the COVID moratorium, at the same time that I started hearing about this new thing, trank, I started seeing meth pretty much everywhere. About a third to a half of the corners that used to sell heroin, cocaine, and crack were now selling methamphetamine as well, and it was taking off very, very quickly. And we're going to talk about why that is the case, why it suddenly had this newfound appeal, right? Meth had been restricted in the East Coast. Meth had been restricted. Meth use, for the most part, was restricted to queer scenes. It has been known as a party drug or a club drug among men who have sex with men predominantly. And that was the case for a very long time. But suddenly, starting around 2019, 2020, meth very much became kind of like a straight drug, right? Like the unhoused folks who inject drugs, who used to only do heroin or cocaine, were now doing dope and meth, right? The West Coast is interesting because it has always had methamphetamine in the street supply, right? And that is still the case. But with heroin's displacement from the West Coast, something that is relatively new and very interesting is that the West Coast becomes increasingly a pill market. So where it used to be predominantly a black tar heroin market, it is now predominantly a pill market where people advertise the pill as though it were an oxycodone or a Percocet. But increasingly, it is the case that these are pressed pills that contain fentanyl. There are still certain spots where black tar remains a thing, and it is very interesting. There's parts of LA, parts of New Mexico that still offer black tar heroin. It is the last remaining little bit of heroin left in the street drug supply in the United States today. And those of you who live in spots where black tar is still available have a very interesting research opportunity, and public health opportunity in studying kind of the relationship between a black tar heroin market and this new counterfeit pill market. I was recently in Seattle, and I was very surprised to see that among the unhoused people who use drugs that I normally work with, nobody was injecting. Everybody was crushing these fentanyl pills and smoking them. And so we're beginning to see a kind of very mixed, complicated story of drug preferences and preferences related to the way that people like to administer drugs, to use drugs, right? It seems to be a moment where people are going to continue injecting in the East Coast and in the Midwest, but turning increasingly to smoking in the West Coast. So again, I think it is important to understand, in order to understand xylazine, it is important to understand the changes that came before, right? We talked about how even understanding that the heroin market was important to understanding the way that fentanyl spread. All these things are necessary to understand how xylazine spread. When talking about fentanyl, one thing that I always insist on is that we're used to hearing this language, right? That fentanyl is more potent than heroin. And indeed, it is true that fentanyl is a much more potent respiratory depressant, right? It depresses your breathing. And so it is indeed much more likely for a person to die of a fentanyl overdose than a heroin overdose. That is beyond dispute. But in many, many other ways, fentanyl is actually an inferior drug to heroin. I've been speaking to people who use drugs on a daily basis for 15 years now. And those who had experience with like the very high quality heroin that we used to get in the East Coast before fentanyl's emergence, before 2013, basically, those with experience with that high quality heroin very quickly realized that fentanyl was inferior in many ways. People describe the initial rush of fentanyl as indeed being a bit deeper than heroin's initial rush, those ecstatic first 15, 20 seconds after injection. But then they saw numerous problems with the fentanyl experience. I'd say the one that is most well known now, thanks to this emerging literature on xylazine, is that fentanyl has a shorter metabolic half-life than heroin, right? So it lasts much less than heroin. And most importantly, it brings on withdrawal symptoms faster, right? And this is a problem for an unhoused person who uses drugs, right? Because if they experience withdrawal symptoms faster, it means that they have to find more money to buy more dope, right? And it means that they're going to have to use more frequently, more times throughout the day. And that means that they're going to be reusing needles more, sharing syringes more, right? So fentanyl actually, and it's surprising how little this has actually been remarked on in the public health literature. Fentanyl actually has another set of risks that are intrinsic to its consumption that have to do with just increasing, frequency of injection and increasing sharing and reuse of syringes. Another thing that is very underreported in this literature is that veteran people who use drugs describe the quality of the fentanyl high as being much inferior, very inferior to heroin. Fentanyl is described as having a much more localized high. Heroin was always described as this kind of holistic, full body experience that would last 10 to 12 hours. Whereas fentanyl is often described as having a much more localized effect, concentrated kind of like in the neck and the face. People describe it as a kind of flushing feeling in the face, not nearly as satisfying as that holistic full body embrace of heroin. And interestingly, it is these deficiencies of fentanyl, all these reasons for why fentanyl is inferior as a drug that opened the space for the emergence of these other new adulterants or enhancers and even new substances. This is what opened the space for xylazine to enter the US drug supply. And it also made a space for meth to enter the East Coast drug supply and really take off as a thing. Let me go to the next slide. So this is, this is one of the first interviews I did, one of the first conversations I had with a person, an unhoused person who uses drugs in Philadelphia, who described to me the differences between heroin and fentanyl and xylazine. Again, this is from Philadelphia, and I'm just going to read this quote because I think it's very, very insightful. This is essentially how I began to learn about xylazine. So this is a person that I've named Tom. This is a pseudonym, of course. He said, fentanyl is such a short-lived high that the high, it's a good high, but it's so short that the nod is over real quick and you get sicker faster, you get dope sick, you get withdrawal symptoms faster, right? See, the tranq, the xylazine extends the high. It gives the dope more of a heroin effect. It's a good rush with a heroin-like legs, right? This is a word that is commonly used to describe the duration of the high, legs. But they straight put bags out there that are just all tranq, all xylazine. You shoot it, you feel no rush. Very important detail for a person who cares about public health implications and the details of the experience of drug consumption. Xylazine, no rush, right? Heroin had a great rush. Fentanyl had a deep rush. Tranq doesn't. Tranq fent, there was already very few months into this phenomenon, there was already a term for the combination of xylazine and fentanyl. Tranq fent. Right? Tranq fent is like you shoot it, you get the rush of the fentanyl, then the tranquilizer comes in, you nod and you fall asleep. Whereas a straight tranq bag is like you shoot it, you get no rush, you're sitting there for a second talking, and then you're waking up 2 to 3 hours later in a weird position. Like one case, I lit a Newport, right, a cigarette. I shot a bag with a Newport. I woke up with a hole of Newport burnt into my stomach. You could literally drown in a ½ inch of water if you did a tranq bag and you fell out. So to me, this quote and many others like it helped us understand how why xylazine was emerging as an important adulterant at that moment of time, right? The fact that the length of the fentanyl effect was shorter than heroin's, the fact that the quality of the high was inferior to the heroin high, those were compelling reasons for xylazine's success as an enhancer, as an adulterant, right? Xylazine not only extends the sedative effect, it staves off the onset of withdrawal symptoms, which is key, right? That's what matters the most to an unhoused person who uses opioids on a daily basis. They don't want to get dope sick, right? Dope sickness, heroin, opioid withdrawal is one of the most torturous experiences a human being can experience. I don't wish it on my worst enemy. This is kind of enemy number one for a person who has a substance use disorder related to opioids, right? They want to stave off withdrawal symptoms. And so the fact that xylazine does that is a very compelling reason for its success. And also in terms of kind of like a holistic full body embrace, xylazine brings a little bit of that back. It's described as not being as satisfying as heroin, but it does add a component that is more holistic than fentanyl's relatively local effect. And then for people who sell drugs, xylazine also compensates for some of fentanyl's deficiencies, because fentanyl is such a potent respiratory depressant, right, that it does have the potential to kill many customers. Lo and behold, suppliers don't want that to happen, right? And so this was always a problem, because you could only use a very small amount of fentanyl, and then you had to bulk up the substance significantly using components that you had to figure out. It's not an easy task. Heroin was long enhanced, or not enhanced, but bulked up with substances like mannitol or lactose, vitamin D, things like this, things that were easy to dissolve in water. But fentanyl presented a problem because it was so potent, you could only use a tiny amount, and then what do you do with the rest of the substance? And so xylazine actually came in to compensate for that, or to make up for that problem. It was a way to address that problem, because xylazine is not as potent a respiratory depressant as fentanyl, right? It is not as lethal. This is something to bear in mind. We're going to go over this. Xylazine does indeed unleash a great number of health complications, but it is not as lethal, right? It is not a potent respiratory depressant. Most fatal overdoses that you see today are fentanyl overdoses, not xylazine overdoses, even when xylazine is co-involved. And as a result, suppliers can use a significantly large amount of xylazine compared to the amount of fentanyl that they put in each bag of dope, right? So this is important. Xylazine was also useful for suppliers who needed to bulk up the substance. And in fact, there's a very good drug checking program in Philadelphia that has been finding, they test samples from the street supply periodically, consistently and systematically, actually. And they found that the average dope sample in Philadelphia is comprised of 2 to 10% fentanyl and 30 to 40% xylazine, right? So suppliers are using much greater amounts of xylazine. And it's further proof that xylazine is far less lethal than fentanyl, right? You can use 30 to 40% xylazine and not kill off your customers. I'm going to go over this relatively quickly, because this information is actually, this is from the first publication that my team and I wrote in 2021. It was published in early 2022. It was our first attempt to get the word out about xylazine, and also to determine how far xylazine had spread throughout the country. At that time, Philadelphia by far had the highest prevalence of xylazine enhancement in its opioid supply. 34.7% of overdose deaths in 2020 in Philadelphia already co-involved xylazine and fentanyl. Again, fentanyl really is what caused the overdose, but xylazine was already present in 34.7% of those deaths, meaning that the prevalence of the substance was clearly increasing. The state of Maryland, the state of Connecticut were already experiencing significant prevalence of xylazine. Uh, and one thing that came out in our research that again is very important to keep in mind is that fentanyl was present in 98.4% of xylazine involved overdose deaths. Right, this is just the fact that nobody is using xylazine alone, right? Like you can't go to a corner and buy tranq. What you're buying is dope, and that dope is a mixture of fentanyl and xylazine in different kinds of concentrations. But again, at least in places like Philadelphia, the concentration is actually relatively consistent. The average of sample is 2 to 10% fentanyl, 30 to 40% xylazine. Yeah, this is where this slide is on the drug checking program in Philadelphia that is showing these relative concentrations of the substance. And I think, by the way, that this is a major public health intervention that everybody should initiate if it doesn't exist in your locality. There need to be drug checking programs that are testing the drugs on a daily basis in order to tell people who use drugs and also public health service providers what the substance actually looks like, right? Xylazine test strips, fentanyl test strips are great, but they only tell you whether the substance is present in the supply. They don't tell you the relative concentration of each substance, and that's the information that we need. And surprisingly, very few cities throughout the country, even the most progressive ones, have an effective program that publishes this data online for everybody to access, right? Philadelphia was actually a pioneer in this, and its program is really a model for the rest of the country. This is the latest DEA data on basically one of the measures that we have in order to determine xylazine spread throughout the country, which is overdose deaths where xylazine has been detected. This data has to be taken with a huge grain of salt because different jurisdictions have different testing protocols. Some jurisdictions are not even testing for xylazine yet. So these numbers are likely to be, in reality, much higher than the ones that the DEA reports. But in terms of relative presence by region, I think it is quite accurate, in showing that the prevalence of xylazine in the drug supply in the East Coast and in the South is much larger than in the Midwest or in the West. I think these, in terms of magnitude, these are accurate representations of the presence of xylazine in the country's drug supply. So now I mentioned all these ways in which xylazine compensates for fentanyl's deficiencies, right? All these ways that xylazine is actually kind of like a good drug from the experience or from the perspective of people who use opioids or sedatives on a daily basis. But of course, needless to say, xylazine also introduces a whole host of new health complications, right? And it's important to have them in mind, right? So as I mentioned, xylazine is not an opioid. Even though it is very unlikely for a person to suffer a xylazine overdose, you need a very, very significant amount of xylazine to have a xylazine overdose. We do need new overdose reversal agents to complement naloxone, right? Naloxone still has to be the first substance to be administered when one suspects that one is witnessing an overdose. But we are going to need a new reversal agent, right? There are reversal agents for xylazine that have been used in animal context for a very long time. More research is necessary in order to create these reversal agents for humans. Now, one of the most significant problems related to xylazine, and I'm sure you'll know this, has to do with these skin wounds that are different from traditional abscesses, right? These gaping wounds that are putting many people at risk of amputations, right? Many people are losing limbs as a result of these kind of very difficult to treat wounds. And we're going to talk a little bit about that, the wounds specifically. There's another concern, particularly from the point of view of unhoused people who use drugs, and that has to do with the fact that xylazine causes people to fall asleep for long periods of time in awkward positions. right? Number one, this might be a problem that is compounding the skin wound problem, because those of you who work in hospital context know patients who are bedridden for long periods of time often develop bed sores, right? And nurses and doctors are instructed to move patients around in order to prevent bed sores when a person is basically in bed in the same position for a long period of time, right? Unhoused people who use drugs, likewise, are falling asleep on the pavement, not even on a bed, for 4 or 5 hours in very awkward positions, right? So this is certainly something that is, if not causing, at least aggravating a lot of the skin wound problems that we're experiencing, right? And it's important for frontline service providers to keep this in mind and to move people around, to shift people's position when you see them lying on the street unconscious from a xylazine high. Something that women are saying in Philadelphia increasingly is that they are concerned about the risk of sexual assault. And there has been an uptick in sexual assaults in Philadelphia linked to this xylazine-induced sleep, right? And then there's questions related to the treatment of withdrawal and detox that are going to have to change in this new context, right? We cannot treat people simply for fentanyl withdrawal and detox in hospital context. We have to treat them as well for basically for combined fentanyl xylazine withdrawal. And there's really good literature coming out of Philadelphia where doctors are proposing new protocols for the treatment of patients who are showing up at the emergency room with combined opioid xylazine dependence. And I'm going to refer you all to this literature. The references at the end of this document, which is going to be shared with all of you at the end of this presentation, contain a couple of articles that I think are very helpful to those of you who are interested in that. Okay, so again, it's very important to keep in mind that it is, most of the time when you witness an overdose, you're not seeing a xylazine overdose. It's very difficult for a person to overdose from xylazine, actually, right? Most of the time it's going to be a fentanyl overdose. Naloxone has to be your first recourse, right? But in those cases when you suspect an overdose that involves xylazine, you want to focus on putting the person in a recovery position sideways to open the airways, right? The problem of an overdose is always breathing, right? Fentanyl causes respiratory depression. That is why a person dies. They stop breathing and they die, right? I'm sure you all know this. I'm sorry, right? One thing that has been very effective in Philadelphia is service providers carrying pulse oximeters, right? A lot of us have pulse oximeters that measure the oxygen levels in the blood after the COVID era, when we were all concerned about the level of oxygen in our blood. This is one way in which you can determine whether a person is breathing normally or not. Most people in xylazine-induced sleep are breathing normally, and when you apply a pulse oximeter, you will notice that their oxygenation levels are perfectly fine, right? And this is something that's important for service providers, because when I first visited Philadelphia in the Trank era, I was kind of shocked at the number of people who were lying unconscious on the pavement, and to me, it kind of looked like an overdose, but it wasn't an overdose. It was xylazine-induced sleep. It wasn't a fatal overdose. And a lot of service providers are showing some degree of confusion at the sight of kind of like a xylazine-induced sleep. And it's important not to rush to the conclusion that the person is going through an overdose, because if you administer naloxone to a person who's not overdosing, they're going to be very angry at you, because you're going to send them into withdrawal, right? You're going to unleash dope sickness on them, which is basically torture, right? You're giving them torture. You think you're saving their life, but really you're torturing them. If you are inexperienced and you witness one of these potential overdoses, yes, you want to go to naloxone, because it's better to torture a person than to kill them, I suppose. But you do want to be cautious. I do think it's incredibly important to carry a pulse oximeter to be able to determine whether what you're witnessing is truly an overdose or not. You'll be able to determine it fairly quickly with a pulse oximeter, because otherwise you're going to be antagonizing a lot of people. If you're just kind of like trigger happy with naloxone, right, you will be torturing a person if you administer naloxone when they're not overdosing. And let me move relatively quickly to the following slides because we are running out of time, right? Something that I did want to mention is different hypotheses that have emerged around the reason for xylazine-related skin wounds. The biological mechanisms behind those wounds have not yet been determined. It looks like there's a variety of xylazine-related skin wounds that are appearing for different people at different times. But some of the mechanisms actually were first proposed by the public health literature from Puerto Rico, right? So number one is that xylazine is a vasoconstrictor. It constricts your blood vessels, constricts the flow of oxygen to the skin. So lack of oxygenation at the spot of the wound is a major cause and aggravator of these skin wounds. And now the thing also is that it is very common for people who inject drugs to inject into the wound. First of all, because the xylazine is a painkiller, right? It's a sedative, so it provides relief. And also because due to the reason that xylazine is a vasoconstrictor, it impedes vein access. After a little while, people start losing access to their veins, right? And the wound becomes a place for people to inject where you can not only relieve the pain, but also feel the effect of the substance more, right? I mentioned the question of bed sores as a potential complicating factor behind the wounds. And it's also very common for people to pick their skin, right? And, you know, you'll know that unhoused people don't have access to, you know, high infrastructure for hygiene. You know, they don't have access to showers very often. So skin picking, especially in the context of meth use, now that meth use is becoming more prevalent, it's very common, and that also aggravates wounds. I'm not going to have time to go over the detailed description of problems related to wounds. I hope we can address some of that in the Q&A. I want to warn you that the next couple slides include photos, very graphic photos of some of these wounds that were provided to me by a doctor who's a friend who studies and actually sees patients who are showing up with these kinds of wounds. Her name is Kimberly Sue. And this is kind of just to show you that there's a variety of types of wounds. Now, I do want to just very quickly, I'm not going to have time to read this quote, but it is very important to know that dope, fentanyl xylazine, combined fentanyl xylazine is increasingly being used by people alongside methamphetamine. And one of the reasons for methamphetamine's newfound appeal has to do also with the problems related to fentanyl, with the inferiority of fentanyl as a drug. People in Philadelphia described to me that methamphetamine, like xylazine, also helps to stave off opioid withdrawal symptoms for a little while. Methamphetamine gives you an extra 4 or 5 hours of energy to make more money to be able to buy more opioids in order to stave off opioid withdrawal symptoms, right? And this is very important for unhoused people who use drugs. In Philadelphia, most of the men who are unhoused scrap metal to make a living. Women trade sex for money. These are nocturnal activities. Methamphetamine gives you that extra energy that you need in order to work longer into the night, right? And so some of the reasons for methamphetamine success as a new substance in the East Coast of the United States have to do with similar issues as xylazine success, right? The fact that you stave off withdrawal symptoms for a number of hours if you use methamphetamine. Now, interestingly, meth is, even though it's kind of following a similar logic, it's a synthetic substance that's replacing a formerly organic, agriculturally derived substance. Fentanyl replacing heroin, methamphetamine replacing cocaine. Even though it seems to be following the same path, meth is actually the opposite, the inverse of fentanyl. Not just because it's a stimulant, but also because, you know, if fentanyl has a shorter length than heroin and it has a more localized high, meth is the complete opposite. People describe it as having a much longer, holistic, full body, satisfying effect than cocaine, right? So similar concept, similar process, but completely different experience from the perspective of people who use drugs, right? Fentanyl is short and local. Meth is long and holistic, full body satisfying. Now, yeah, I'm very sorry because I realize I'm running out of time, but I do want to hone in on the HIV aspect of this. And I do want to say that, first of all, there's not a lot of literature on this, right? On the relationship between xylazine, meth, and HIV. There is a lot of literature on methamphetamine and HIV, right? And it's literature that allows us to see that this is going to be a complicated era. It's going to be difficult to tell the story of this era because I think we have a lot of countervailing forces going on. Not everything is pushing towards increased risk. Xylazine, actually, in extending the sedative high, is leading people to inject fewer times throughout the day, which means reusing needles less, using needles less. And that's actually going to have a protective effect from a public health perspective. Methamphetamine, on the other hand, has long been linked to higher risk behavior, and it has been linked to higher prevalence of HIV and HCV among people who use it, right? So you have these countervailing forces, and very careful research is going to be necessary in order to determine exactly what the HIV impact of all these things is going to be. Now, with xylazine, it is very important to keep in mind that the problem of stigma is going to be increasingly a problem, right? People are developing these very ghastly skin wounds throughout the body. They're very embarrassed of them. So the stigma that already exists in hospital context against people who use drugs is now going to be compounded. You know, a lot of nurses, doctors don't want to treat these patients. The patients are even more embarrassed than they used to be, simply because of the way their body looks, right? So it's going to be very important for HIV service providers to be proactive about reaching these patients. You're going to have to go to where they are. Or, you know, you can't wait for them to just show up at the hospital. You're going to have to join teams of wound care specialists who are already doing this kind of outreach, or harm reduction specialists who have already been doing this kind of outreach for a very long time, to deliver the type of care that you provide in order to make sure that people access HIV testing, medication, that ensure that people adhere to these medications, right? This is kind of the most important message, I think, related to HIV in this new context. Okay, I have some other suggestions, but I think we should stop it there for now. I can get to these suggestions during the Q&A, and I'm happy to stay as long as necessary to answer all your questions. So should we do that?
Yes, that would be great. Thank you so much, Dr. Montero. So thank you again for that extremely engaging and informative presentation that you gave, and really trying to address all those questions that we got from registration, and really setting the background for why we are where we are in this epidemic. So we do have several questions that I want to get to in the Q&A. So I will start with, how can I recognize and respond to an overdose or medical emergency related to xylazine and fentanyl?
Yeah, so this is something I discussed during the presentation in light of that question. Right, number one is naloxone should always be your first recourse. If you are a veteran and well, let's start this way, right? If you are relatively inexperienced as a service provider, I would say go for the naloxone, because you can't do what a veteran does, which is to be able to distinguish between, say, a long-term xylazine-induced sleep and a fentanyl overdose. But to those of you who are veterans, you know, and even to rookies, I would recommend the pulse oximeter. Carry the pulse oximeter to be able to determine whether a person is breathing. Absolutely, you need to learn CPR. Rescue breathing is crucial. And in the event that you don't have a pulse oximeter, or that you see the person's lips turning blue, absolutely administer the naloxone.
Before I continue the Q&A, I just want to reiterate what Dr. Montero said, that he is willing to stay. Our session is scheduled until 1 p.m. Eastern time. So if you are able to stay with us, Dr. Montero will try to get through as many of your questions. We hope that you can stay with us. So Dr. Montero, do people use fentanyl xylazine via inhalation as well as injection?
Yeah. So in most markets in the country, it's a powder. So in the East Coast and the Midwest, most people are well, actually, in my experience, most people are injecting it, but there are lots of inhalers as well. Yeah. In the West Coast, as I mentioned during the presentation, it's increasingly prevalent for people, or it's increasingly common for people to smoke, to buy the substance in a pill form, crush it, and smoke it.
And can you further define what you mean by trank era, the difference between that and injection?
So by trank era, I just mean that the era where xylazine is prevalent in the street drug supply, right? And again, it's a little bit of a misnomer because nobody's going out to the street to buy xylazine, right? And it's not even really available on the street. What you're getting is a combination of fentanyl and xylazine. So trank fent, right? As people said in Philadelphia, as people call it in Philadelphia. More research is necessary on how that's changing preferred modes of drug administration among people who use drugs, right? I haven't seen a lot of papers showing whether people are moving away from injection because of the increasing prevalence of xylazine in the supply. We know it's happening in the West Coast kind of organically because of the change in the formulation on the supply side of things, right? People who sell drugs are selling the pill instead of the powder. And people are smoking, which from a public health perspective changes the landscape of risk, right? Because now you don't have the risks related to injection drug use. Now you have a separate set of risks related to smoking. But there is no clear story yet as to how the trank era is transforming the way that people use drugs. More research is necessary on that front.
So are there any recommendations on how to engage people who use these substances on a less than daily basis and/or people who use drugs by means other than injection?
This is an important question. Yeah, I mean, I do think that as I mentioned at the end of the presentation, it's increasingly important for service providers to be proactive about reaching out to folks because stigma is being compounded in this era as a result of the skin wound crisis related to xylazine. So people aren't showing up as much in clinical or hospital context, right? So we need to go out to meet them where they're at, right? So I think it's just increasingly important for service providers to team up with harm reduction service providers who have been doing that kind of outreach for a very long time, to find alliances or to develop your own outreach programs, right? There's an army of wound care specialists emerging around xylazine, which is a great, it's a great thing that this is happening. And one possibility would be for, say, HIV service providers, SUD service providers, and wound care service providers to all team up in order to conduct this outreach in a joint fashion, right?
So kind of going back based on what you said, so what would be your recommendations for treatment for individuals who do not have consistent health care and cannot be in treatment settings for long due to substance use urges?
Yeah, again, it's a question of outreach, right? You're gonna have to take the hospital to the street, right? Harm reduction has been trying to do that for decades already. We need more of that, right? We need an expansion of that. We need hospitals, doctors, nurses to think of themselves as harm reductionists in this era, essentially, right? You need to go out to the street. You can't stay in the hospital anymore. And of course, those of you who have no option but to stay in the hospital or the clinic, combat stigma in your hospital, in your clinic. Make sure that people who have these nasty skin wounds, are people who use drugs in general, have full access to your services feel comfortable in your space, in the hospital context where they often don't. And that's something that's going to depend on the hospital or the clinic where you work, right? You have to be proactive about how to make those people feel comfortable.
As others probably have as well, I have heard from people who use drugs, harm reductionists, that these xylazine wounds occur in people who do not inject and in other places on their bodies other than the injection site. What do we know now about why this is and what can be done to prevent or address these wounds specifically in street medicine efforts?
Yeah, there's a heated debate around this right now in the public health literature with no clear winner right now as to whether all the wounds are related to injection or whether people who inhale or smoke also develop the wounds, right? I mean, I work in Philadelphia. Prevention Point is the biggest syringe service program there. The wound care specialist at Prevention Point swears, right? And I'm inclined to believe her that smokers and inhalers are also developing the wounds. There's many possibilities, right? Like one possibility is that injection wounds are different from the wounds that the folks who inhale and smoke are, right? Like the inhalers and the smokers might be getting the bed sores that I was talking about, right? Whereas the injectors might initially be getting a wound related to the direct physical process of injection, right? But much more research is necessary in order to really determine whether that is the case. At this point, I think from a service provider perspective, I think it's just like I think we should just focus on the problem of skin wounds, right? Intensify education around skin wounds and service provision around skin wounds, right? Independently of how people are developing or not.
Is there any evidence that xylazine might cause acute hypertensive crisis upon discontinuation, as is the case with clonidine?
Yeah, there's questions around xylazine withdrawal that are very specific to xylazine and not opioids, right? Which is why I was referring you all to the literature from Philadelphia that is coming up with the protocols for the treatment of patients who show up often for skin wounds and need to be treated for combined fentanyl xylazine withdrawal, right? Hypertension seems to be one of the problems. I am not a clinician, so I actually, I would just refer you to the literature. The literature is very clear. These are like articles that are 2-3 pages long. I think those of you who work in clinical contexts or in harm reduction should really read them. I mean, let me just pull up their bibliography very quickly to direct you to the articles that you should read. I don't have that. Actually, this article is not listed here. I'm sorry. But I can modify the bibliography after this after this finishes, and then the updated version to Liz, and Liz can forward it to you all with the updated references.
Absolutely. And how would you address recovery centers that are abstinent based? It sounds like it would be pretty brutal to not have any additional coping tools when coming down from these substances, yet these are requirements to even get into treatment.
Yeah. So the literature that I'm referring to also has suggestions on how to address all the complications related to combined fentanyl xylazine withdrawal. Right. Again, I'm not a clinician. My realm of expertise really is kind of like on the experience of consumption from the perspective of people, on how people who use drugs on an everyday basis. The slides do contain a list of medications that are used to alleviate symptoms related to withdrawal. Please do refer to those slides. But I would be doing a disservice to this information if I go into trying to explain it as a non-clinician.
So with that said, there's one more question I think that would be appropriate, and the rest I think are, as you mentioned, a little bit more clinical based. But with these findings and points around xylazine, is there any reconsideration from the Philadelphia City Council to remove the ban on overdose prevention centers? Seeing that Philly is a high impact city, I would imagine they would want to consider an OPC.
Yeah, this is a significant problem. Philadelphia is a pioneer in some senses and then incredibly regressive in others, right? Philadelphia was supposed to have the first overdose prevention center in the country, but their efforts took place during the Trump administration, and the Trump administration just came down on it as hard as it could. That center got blocked, and there's been legislation at the state level and then at the city level even, which is incredibly surprising considering that Philadelphia is a democratic city, you know, which just speaks to all the work that we still have pending, even in blue states, right? To demonstrate that overdose prevention centers are an effective public health intervention that alleviate many of the problems related to extensive substance use. Right. Another thing to keep in mind related to OPCs, overdose prevention centers, is that in the xylazine era, they're not only going to be helpful to prevent overdoses, they're also going to be helpful to prevent sexual assault or mugging linked to the fact that people are falling asleep in awkward positions for extended periods of time, right? So overdose prevention centers aren't just overdose prevention centers. They're many other things, right, that make them effective as a public health intervention.
And actually, I do have one more question, Dr. Montero. So what is the percentage of fentanyl in the supply, and is there still a benefit to fentanyl test strips given that they do not test for concentration? Yeah.
So this is different in different cities, right? And I told you about Philadelphia, where the average sample is 2 to 10% fentanyl. In other cities, it's bound to be different, right? Now, as to fentanyl test strips, most people who use opioids don't test their opioids on their dope anymore because they know that fentanyl is in the supply. They're more interested again in the concentration than just the presence, and that's why we need kind of like a democratization of spectrometry technology that would help us determine at the very local, very real-time basis what the supply looks like on a daily basis. But given where we are, fentanyl test strips are very useful for stimulant users, people who use meth, cocaine, crack, and for people who use pills, because the supply is much more uncertain when it comes to meth, when it comes to pills, right? There, you don't always know what you're getting. And so for those people, it's very important to use fentanyl test strips. In Philadelphia, meth is actually surprisingly pure, but this same drug checking program is showing that meth is 100% pure. It never has any fentanyl. But in other parts of the country, including New York City, where I live currently, many methamphetamine samples are showing up positive for fentanyl. So yeah, they continue to be very important, just not for the opioid users.
Great, thank you. There are a few more questions in the chat, but I think at this time, Dr. Montero, thank you so much for staying over with us, and those who were also able to stay over time. Dr. Montero, if anyone has some additional questions and wanted to learn more about your research, would they be able to get in contact with you, or is there a way? And if you could provide that information in the chat, I think that would be really helpful for our participants. So with that said, again, I cannot thank you enough for joining us and giving this presentation, and all those who were able to stay with us throughout this session. Ashley has added the link to the evaluation, so we want to hear your feedback on the session and feedback about additional training needs. We also look forward to our next session that will be in November, and we look forward to your participation. That information is on the website, and I believe Ashley did add that information in the chat. The next session will be on November 3rd, and that is Law and Disorder, How the War on Drugs Impact Drug User Health. So we look forward to your participation then. And if you have any questions, again, you can feel free to reach out to us. So thank you, everyone, for your time, and enjoy the rest of your day.
Thank you all.